have Dr. Gavin Britz. Dr. Britz is the director of the Houston Methodist Neurological Institute, chairman of the Department of Neurosurgery, and the Candy and Tom Knudsen Centennial Chair in Neurosurgery at Houston Methodist Hospital. He is also professor of neurological surgery at Weill Cornell Medical College. Dr. Britz leads a team of acclaimed neurosurgeons and affiliated professionals and is recognized as one of the nation's foremost cerebrovascular, skull base, and brain tumor surgeons, and is included in the Masters of Neurosurgery book. He has received Best Doctor in America distinction 6 different years. He is on the advisory board for the Joe Negro Foundation. I could go on for a long time.
Yeah, this will be ridiculous. Anyway, so Jay, thanks for inviting me. I'm going to tell you, my talk's going to be a little, I'm glad it's dovetailing with Raj, but I hate to tell Raj that a lot of this talk that he's going to talk about today is going to be outdated pretty soon. So what I'm going to show you guys is how we're going to do strokes remotely long term and how it's going to change the workforce needs. Even myself, I'm really surprised at how rapid this has developed, because I'm on the safety data committee for the robot that's coming out, and we're expecting approval in the next 6 months, and then we'll start endovascular, robotic endovascular stuff, and we'll start robotic stroke hopefully within the next 2 years. So I'm going to just give you a background for where we started, and I can tell you now there's a lot of duct tape involved as we got this going. So disclosure is just an R21 and a DoD grant. So this is a slide that's going to just show you exactly what we're planning to do. So look at the top of the screen, you find a humanoid, which probably we're all going to be our grandkids and our grandkids' going to look like. Jay's already looking like that. But anyway, and then you can see us, sitting down here in Earth, and we can you treat this remote stroke? So when you look at this as science fiction, you can imagine, well, can I take a catheter from someone's brain, from someone's groin, put it in their brain, take it out, in space, and people say there's no ways. But I'm going to show you how it is possible, and we've started that already. Not space, but pretty close. I think the first step, and I'm a big open vascular surgeon, and I think as Alex knows, and Jay, that's what I prefer, but obviously I do endovascular as well. But what changed this whole paradigm shift is the shift away from open vascular surgery towards endovascular. And the reason it happened, it's faster, it's safer, it's more cost effective. It's occurred, of course, across all specialties, cardiovascular, peripheral, neurovascular. And the shift was we have a vascular highway. You can go to the groin, go through the radial artery, and you can access any part of the brain, and it just makes more sense. And that's really started. So you always grow from your forefathers. So someone before doing research that doesn't seem important can lead to a massive discovery. The guy that did the first angiogram, that he believed that's going to lead to telerobotic stroke intervention and no, he didn't even think about it. But that just shows you how important it is to do science and keep on making the world a better place when you arrived. So the 4 major reasons people started looking at robotics was automation. I think that humans are fallible, some more than others, when you watch the news and our politicians. But I think that robotics can help automate things and make things safer. For example, if you can imagine pinning the wire, you put the aneurysm in the wire in the aneurysm and pin it, it doesn't move forward, your fellow's going to perforate. We've all had perforations before. Obviously, remote stroke's been on the thought process for quite a while. Remote proctoring, when you go proctor someone, you've got to climb in a plane, fly out there, to waste your day, waste their day, and I think also radiation exposure. So those are the 4 major reasons I think that's made people think about how we can do telerobotic stroke, but also robotic intervention. I haven't seen this movie, but I've got the slide, okay? And I've heard it's a great movie, and I've really got to watch it at some time. But I think that we are in the stage now where we're interfacing with robots. I think, as you know, I think Jay and them know, we started a neuroprosthetics program, which is exactly that. We're going to be interfacing, placing chips in people's brains, and replacing functions. And I think we are really at this time of the matrix now. So we started this thinking, well, how we can get this, robotic neurosurgery done. So there was a robot called the Corindus robot, which is a cardiovascular robot. So we took that robot. So we took that and said, well, that's just been used for cardiovascular, never been done for brain. And the first study was, what's the feasibility of using the neurovascular microwires, the neurovascular catheters? And as you can see, we published this already in 2020. And it was just testing the wires. We use this robot, we use it in a flow model, and I'll show you the ground base. This is what the robot system looks like. You've got your console on the right-hand side, and your machine, which I'll show you later, That's the robot. That's all it is, and it's a primitive robot, which we started with, but it's evolving, and I'm working with a German company to make it better. But that's what the core part. Very, very simple. But that's what we started looking at, how we can do robotic interventions. And I'm going to show you some videos. I can talk less.
This is the operational video.
I'm not sure the volume's there, but as you can see, so this is me now. So you can imagine, we're driving a wire. I'm sitting behind the console. There's the robotic thing moving.
Manipulates the
And
microwire and microcatheter. The top right panel is the cassette that actually manipulates and drives the wires. The lower two panels demonstrates the flow model, driving and navigating the microwire and microcatheter.
so this was the first in the world that we said people could do this. We took the cardiovascular robot, used the neurovascular wires, used the flow model. It's not showing you, but we started doing that. So that's and this was duct tape. I can tell that now. And this is an example. Again, now we're not. I'm so used to putting my microcatheter in my hand. This is the first robotic coiling of an aneurysm using a flow model.
Using micromanipulators, we then coil this aneurysm in the flow model using the robotic device.
So this, yeah, this.
After we partially coiled the one aneurysm, the microcatheter was then partly removed and pulled back to evaluate further coiling and painting effect of the stiff coil that was used. This was very successful, both in navigation and delivery of the coil.
So you can just see, this was like 2.5 years ago. So this is the first time. This is, not me sitting with my microcatheter, my microwire, controlling everything. I'm sitting in a console, and I'm using at that time just 3 joysticks to do this, because we were pretty excited, okay? Then we said, well, let's take it away from the flow model, and let's do it a pig model. And that was the pig model. Let me show you this one now. So I'm just showing you guys the groundbreaking stuff we did here at Houston Methodist.
In this exercise, we robotically manipulated the microwire and the catheter into the internal carotid artery. As you can see now, the microwire is inside. We're now delivering the microcatheter and pulling the wire back robotically.
But again, this was exciting. I mean, no one had done this before in the world. We can do this robotically, and we even could do a run, and that was the first animal done. Okay. Then we said, well, let's take it a little further. Let's see if we can place some coils in a rete of the pig.
In this video, we're using a pig model, and the microcatheter and wire have been driven robotically into the rete, and now coiling of the rete ensued successfully using the manipulators.
Okay, yeah, and just understand, I'm sitting about 6 or 7 meters away from the pig, okay, not touching the pig, just purely doing this robotically. And that's how it started. And then we said, okay, well, now we're going to see if we can take this wire, place it over a stent into an aneurysm.
In this exercise, a stent had been placed robotically previously, and this just demonstrates the ability to robotically navigate the stent and then to go into the aneurysm. As you can see, the wire is navigatable through the stent and then goes through the stent trellises into the aneurysm.
And this was done with the cheapest wires, not the best wires we use now, but even that, we can do that robotically. So then we said, okay, well, and these are obviously different publications. We said, well, we're going to really push this field. We've done aneurysms, we've done, just diagnostic flow model. Let's see if we can embolize an AVM, which is, we use a surrogate for AVM, which is the rete, and we use for dural fistulas, and you can see, same thing.
At this stage, the wire has been driven robotically into the A7 paradiddle artery towards the rete mirabilis. Now, as you can see, we're going to drive the microcatheter, also done robotically, over the wire towards the rete.
All done robotically.
A run was then done from the rete, which just shows supply from the rete towards the cranial circulation. We now use negative roadmap, and onyx embolization is occurring. The rete was used as it looks like an AVM, and as you can see, the onyx is penetrating the rete well. Some reflex is occurring of the onyx, which is operator dependent and done to try and completely occlude the feeding vessel to the rete.
But again, as you say, another publication pushing the frontiers.
Robotically into
I'm not going to show you that anyway. So I think, just to give you an example, I'm going to give you another example where robotics is going to change things. We're surgeons, and I think just to give you one great example. For me, and we're going to start a fellowship for people who are going to apply for endovascular fellowships, hopefully July next year. The biggest thing I always worry about for myself, particularly my fellows who have got inexperienced hands, is you put your wire in the aneurysm, and when you advance the microcatheter, just the traction, the force between the catheter, that wire can sometimes shift. So we said, well, the robot's going to be better than us humans, and let's see if we can get the robot to make that safer, and I'll show you what we did. So then we went ahead, and we developed this thing called active device fixation device, and I'm going to show you how exactly it works.
The microwire is now being driven robotically into the aneurysm.
So there's the aneurysm on the left panel.
At this stage,
you'll see the wire,
and now being delivered into the aneurysm following the wire, as can be seen with the manipulation of the microcatheter over the wire. A large amount of forward force occurs, resulting in propulsion of the wire into the
So that's the biggest thing we worry about as endovascular neurosurgeons.
By the wire.
And as you can see yourself, it happens all the time. So we as neurosurgeons, we pull back the wire as we're pushing the microcatheter to prevent perforation. But obviously your fellow's not going to know that, but that's what happens. So we did this with purely a software fix.
In this case, the wire has been taken into the aneurysm robotically, and now the catheter is taken over the wire. But in this situation, we use the proximal fixation characteristic of the robot to prevent the wire moving forward.
So you can see now when you go, it doesn't jump forward. So what it does, we use robotic technology to make everything safe. So the big question is, obviously this is a stroke talk. Are we ready for stroke? As you can see, I've shown you, we can do AVMs, we can do aneurysms in flow models and in pig models, and all that. As we know, the stroke is, Alex, myself, and Lena's what but we do. This is the bane of my life, middle of the night, but our results are pretty good here. But all it is an occlusion. So we can drive stents with a robot. So why can we not, if we drive a stent over there, why can we not thrombectomy? So this is extremely possible, and we did a few in pigs, but it wasn't successful because the pigs are, they've got a very difficult vascular supply. You don't have an ICA and MCA, but this is possible. I think, as Raj said, why is remote stroke important? I think that you have your stroke up in Aspen, Colorado, or in Laredo, Texas. If there's not going to be endovascular, for someone to get here, it's going to be there's a delay in time. I think, as you said, you lose neurons, but even financially, the data shows that a $66,000 extra expense for every hour that's delayed. So you can imagine, that's where it's going to change the telestroke talk. When he gives it in about 2 years' time, it'll be very, very different. You can imagine, a patient has a stroke in Aspen or Laredo, Texas, and you have a robot there, and a human being can sit here and do the thrombectomy right there. So a patient will be at home, taken to the ER, and then we can really get not only a door-to-needle time less than 60 minutes, we can probably get a thrombectomy time within 60 minutes, and I'll show you how we're going to do it. So this is another paper we wrote, which is the cover of our big journal, and this shows how we would triage these people. But even since then, it has changed, okay? So and obviously we said, well, we're going to try it in humans, and we were first in man to do this in humans as well, using the robot. We couldn't do the aneurysm first, it was in Canada because of the FDA, it's typical, but we are ready to go. So I think that, the big question people say, well, Gavin, how are you going to have the delay, for wires? You're going to treat someone at a remote distance, what's the delay? So we did that with Alan Lumsden, we looked at how much delay you can tolerate. And really, when you look at it, even over a cross distance of a couple of miles, the delay is so negligible using 5G technology that it's going to be completely safe. So the thing about it is, you look at the slide, is this possible now? As you can see, we have the wires, we have the tools, we have the 5G technology. We can probably do it now, except that we cannot get the space. But I think that the last part of the talk is going to be, is we're going to change the staffing models. I think we went through a situation where, when I was training, we had the true spoken model, all the vascular case, all the strokes came to the med center. What happened was stroke essentially changed the whole vascular field in that the hospitals wanted to keep the patients. So what happened, we hired a whole lot of neurosurgeons and endovascular radiologists and everyone to be in the community, so that'll increase the workforce. But my prediction is it's going to reverse. We're going to go back to the spoken word model. But what's going to happen is the patients are not going to come here. The surgeons are going to be at one place. And I think as you guys prepare for your fields, I think we have a way oversupply of endovascular neurosurgeons and endovascular radiologists and even neurologists now. And I think when this robot comes to fruition, which I suspect will be, we will be doing remote strokes within 2 years, you can imagine you can have one surgeon on call at the TMC treating 15 different hospitals at the same time. So I do think this telemedicine is important, telestroke is important, robotics going to stroke is important, but this is really going to change the landscapes. Anyway, that's all I've got. I just want to show you guys, what we did from the ground up. As I said, 2 new robots coming. The 4-channel arrives in about 3-channel will be FDA approved in about 6 months' time, and then the 4-channel is going to be approved in about 18 months' time. Once the 4-channel comes inside, we're going to be doing remote strokes, and we'll start between the Woodlands, probably, and us, or one of the other community hospitals that get going. Any questions? I think I was at 20 minutes, okay?